You know, this is a high energy group, which I love. But God, when you get networking, it's hard to stop, isn't it? So good. Not at all. It's terrific. So good afternoon, everybody. We're going to start the next session. And we actually have a great opportunity to interact with some of the leading experts from their stakeholder communities as we start to look at access issues. But before I start, I just want to make a couple of comments. We've done a lot today. Those who are patient advocacy members spent half the day yesterday looking at universal access issues. And if you're having the same sense I am, there's a great deal of complexity to these issues. And when you look across the world, there are some similar issues, but there are a lot of very different issues. Now, I learned today that there were so many commonalities between the United States and India. And I was actually really surprised at how many similarities there are. But the challenges are so intensely complex that it's sometimes hard to get your arms around them. And I'm reminded of a cartoon that I saw about 20 years ago. And it was a very short cartoon. It was a little kid that was in a schoolroom with a teacher, and the teacher was teaching math. And the kid put his hand on his head. And so imagine he's got his hands on his head, and he's just holding his head. And the teacher says, "Johnny, what's wrong?" And Johnny looks up and he says, "You know what? My head is full." I don't know about you, but we're only in the second day, and my head is full. So my hope for this session is that we will address a very complicated issue, but we're going to try and create a mental framework for ourselves to get our arms around it. One of the opportunities I think we have as we address this session with this panel will be to start to think about what is the specific problem or problems we're trying to address. We're talking about universal access, but what is the problem? What do we have to understand about the problem to make it work? And I borrow this from something I've described at a previous Congress, which is called the arc of public engagement. And it's a very simple tool to help you break down complex problems. And it really has 3 steps. The first step is to identify what is the problem you're trying to solve. The second is, what is the solution to that problem? And it needs to be a solution that is believable. So you need to have a problem that you can understand, and you need to have a solution that is believable. And then if we, all the advocates in this room, are going to take action, it needs to be important enough that we're going to stop doing something we're already doing and take action. When you get an understandable problem with a believable solution, you'll take action to solve it. Now, when we talk about universal access to healthcare, just about everybody in the room is willing to take action. So it's not that it's not unimportant to us. Our challenge is, how do we break down the problem? How do we really get our arms around and understand and communicate with other advocates about what the precise problem is we're trying to solve, and what are the solutions that we can take in this complex world that will actually make a difference? If we can get to that point, we have the opportunity collectively to make action globally and within our communities. So we're going to address the barriers to access with this panel. It's a multi-stakeholder panel, which is really exciting. So we're going to look at these issues from a consumer perspective, a provider perspective, the biopharmaceutical perspective, and the World Health Organization. And we're going to have just a few questions to begin with to set up the issues from the perspectives of the stakeholders represented here. But then we're going to have an opportunity for you to provide a comment or ask questions. But I would ask you to think, as you're listening to the presentations or the answers to these questions, what are the problems and solutions that I heard from this group that I could take home to my community and actually start to make a difference in ensuring universal access to healthcare? So we're going to start by asking each of our presenters to introduce themselves, but as they introduce themselves, to also explain what universal access means from their perspective. Because a lot of times we talk about universal access and we've been using it as if it has a common definition. But it also means different things to different people. So let's figure out where we are. And I'd like to start with Stephen Wright, who's with the Consumers Health Forum of Australia, and ask him to introduce himself and tell us what his definition of access is.
Just arrived.
Perfect timing.
Good afternoon, everyone. My name is Stephen Murby Wright, and I'm a director of the Consumer Health Forum in Australia, a former chair of the same organisation, the chair of the Chronic Illness Alliance in Australia, CEO of Cystic Fibrosis Victoria, and a member of the a board of directors of the Australian Council for Healthcare Standards, and a few other of those sorts of things. I'm actually not here impersonating Fozzie Bear or Kermit the Frog. I am actually losing my voice, which may be to your advantage, I suspect, as the afternoon goes on. I also was on the the advisory panel for this conference and setting the theme. And I guess I'm the one that's responsible for saying, with 80% of the world's population not having access to clean, reliable, hot running water, what on earth are we doing talking about universal health care? And then that got me thinking, and I then sort of listened to the stories of people talking about access to universal health care, and it really seemed to me like on the one hand, the 80% that I was talking about, and on the other hand, a group that was saying, Daddy won't buy me another Lamborghini. And I was thinking, this can't be right. I mean, universal healthcare standards, what am I missing? Why is it that some developed nations sound so already incredibly privileged, and yet sound like they're really hard done by? And other nations that are obviously not privileged also sound like they're really hard done by. And it began to get me thinking about what's the problem with the expression UHC, or sorry, the universal healthcare. And the problem is the word universal. And I realized that it's really my local universe, universal healthcare. Now that isn't to be derogatory, it's actually to say, whoa, hang about. Of course, we're going to interpret this in terms of our local universe, and therefore universal healthcare has issues in that context. So what I've set about doing for today is disengaging myself from my local universe, Australia or anywhere else, and actually said, can I find some global barriers to the access to healthcare, to universal healthcare, that we can all overcome irrespective of what context we're in. So irrespective of whether I'm living in Abu Dhabi or I'm living in Kinshasa, and last year that was the richest and the poorest city in the world, I should be able to come up with barriers that are the same and approaches that are the same, but the context which is totally different. I did my thinking based on cities, not on countries. One, because of the greater acidification of the world, and two, because I sort of believe that you don't have to go far out of a city to find the richest and the poorest people poorest circumstance people in the country. That's not to play down that it's an order or two or three of magnitude greater to roll out programs in rural and regional and remote areas. But you will find them amongst the most disadvantaged and amongst the most advantaged cities. So that's where I begun. I began about people in cities having the ability to get healthcare. Okay. Okay, I will speak more slowly. I think I finished that bit anyway. Oh, what I will add is, because I'm sounding like this, I have actually got a background paper prepared in draft form, and Lizette at the desk said she'd be happy to email it to anyone. So if I'm difficult to understand for whatever reason, Lizette's got the paper.
Terrific. Can I ask Dr. Kloiber from the World Medical Association to respond next from a provider perspective?
I'm not sure that I can give you a provider perspective, because I try to boil this down very simply to a situation that I myself would fit in as a patient, for instance, and looking for care that I would need. And I would like to try to answer this from that side. Now, about myself, I'm the Secretary General of the World Medical Association, and we are the roof organization for currently 106 national medical associations from around the world. To that extent, yes, I'm representing a provider organization, but when it comes to those questions, I think each of us also has at least a second perspective, and that is at one point seeking healthcare yourself and wondering what would be the situation that you would like to see and find. Now, I can't answer your question about defining universal access to healthcare, because I never thought about universal access to healthcare. I thought about access to universal healthcare. And let me try to define that. And that sounds very simple, but I guess we will find out that indeed it is extremely complicated. And I don't have a definition for one part of the world and another one for another part of the world, because I think the challenge is always the same, as a disease is unfortunately not taking into account whether you are getting ill in a rich country or in a poor country. So my definition here of access would be to get effective, quality care a patient needs and wants at the time the patient needs and wants it. And that's basically it. As I said, it sounds very simple, but it has exactly the same challenge as the word universal has in it, because it really asks for a lot. And I hope very much later in the discussion that we can see that there are some examples where healthcare systems are coming pretty close to it. I'm pretty sure there is no healthcare system in the world that really delivers it in the term of being universal, but I think we can discuss, and hopefully can discuss, that there are some examples where it goes pretty well, and we will find out that there are others where it's not so good, and even some places where there is unfortunately nothing. Thank you.
Terrific, I appreciate that. Dr. Montenegro, here's your perspective from the World Health Organization.
Well, good afternoon, everyone. It's a pleasure to be here. I'd like to thank the organizers. Really an important topic for us, so we're very pleased to be here. I'm very pleased to be here. So I'm Hernan Montenegro. I'm a physician by training. I'm from Chile in South America. And at the beginning of my career, I did clinical practice, primary care, and so on. Then I did training in general surgery. But then my heart went towards public health. And so I quit clinical practice and I got involved in public health. At the beginning, public health, epidemiology. And then I moved more towards reform, health system reform, so health policy, health management, and so on. I worked at my own country when we recovered democracy, and we had to restructure and rebuild the public health system. And then I moved, I went and I worked for the World Bank many years, 5 years, and I worked mainly in Mexico, Panama, and Brazil, so saw a lot of reforms there. And since some years I've been at the World Health Organization, first regional office in the Americas in Washington, D.C., and more recently I'm stationed in Geneva, so I have a global perspective from all of the continents from Geneva. I'm a health systems advisor that works for the health system cluster at WHO, and this is a major topic for us. For the WHO, universal health coverage has been the agenda for many decades, but now our Director General has re-emphasized the need to tackle this important problem. So we do have, of course, our policy documents, our definitions, they're quite clear. You can go into the WHO webpage and download them, and probably I can point out to one recent report in the year 2010. It's called Universal Health Coverage, and it talks and has definitions, and I'll briefly say what we say. It's that all people, that's universal for us, all people have access, and here's where we have some distinctions. I think they're important for the audience and among the panelists, because if you talk about health services, for some countries it's different than talk about health care, because there's a main distinction at the beginning. Health care mainly is personal care, individual care. But we see it broader. So we're talking also about access safe to promotion, prevention. And I think this is so people stay healthy. You know, the wellness concept has to come up here. In addition, obviously, to take care when people get ill, or, you know, so it's all people have access to needed health services, comprehensive, from promotion to prevention to treatment to rehabilitation to palliative care to etc. To the whole comprehensiveness of services that is of quality, and that's, we can discuss a lot about that. And also that doesn't mean that the person in accident falls into financial hardship. So it's the issue about that it's affordable as well. So anyway, so this is our definition, and happy to discuss more later.
Terrific, thank you. Let's ask Dr. Sebbag to give his perspective. He's here representing Sanofi, but in just a short time we've met each other and speaking. He really comes with multiple perspectives, so it'll be interesting to hear your thoughts on this. And he's the other one with a mic on his tie.
Okay, thank you, Marc. Good afternoon, everybody. Thank you, Joanna, for inviting me, and I'm very happy to be in IAPO. Why I'm very happy? Because today or tomorrow will be a patient, and I'm a patient. I just want to introduce myself. I am Vice President at Sanofi, in charge of access to medicine, mainly in developing countries, but not only. But I am still medical doctor in a hospital in Paris, and I maintain my medical activity once a week. And I meet patients. I have patients and specialists on infectious disease and AIDS, HIV/AIDS, and I think it's very important to know the two worlds. And I'm a world of pharmaceutical industry and the world of the patient. And before, I was head of the international operation of the Red Cross, just to see that I know many worlds, humanitarian world, the world, I know very well. And perhaps I will say three worlds and 4 pillars when we speak about that. The 3 words for me is partnership. Partnership, it is sure. You are partner. And if you see the list of the Millennium Development Goals, the number 8 is partnership. Without partner, we have to be seated all around the same table. I think it's very important, and for sure, patient, you are very important. The second word is respect. We have to respect all the partners. We face a very, very big gap, and I will come back on this one. And the third word is humility. Humility, because when you see, when you see the reality of the world, the reality of health, to speak about universal health coverage, 80% of the people around the world have no access to essential drugs. I don't speak about service, I speak about water, about hygiene. But we need to dream. I'm sorry to speak about dream. Universal health coverage, it's a goal. We need a vision with a goal and to put all the means. If you remember, if we discussed about 20 years ago, it was impossible to conduct this type of meeting. And very often I say that HIV/AIDS has opened a door for a big awareness about health all around the world. You have to remember that. At the end of the 90s, beginning of the 20th century, suddenly we discover the AIDS epidemic in African continent. Say 35 people there HIV positive. It was the time you say, okay, the drugs are in the north and the patients are in the south. And you remember the Pretoria trial and all the polemics with big pharma. I belong to big pharma. And the only positive point was awareness. Suddenly they say, okay, pharma and the politics, they say, we can go in the same direction because it's impossible. With the globalization of information, how you can have some technical means in the north and nothing in the south. And if you remember very well, it was a creation, is a G8 for the first time, the richest country, it was G7 at that time, in Genova, in Okinawa, for the first time, they have decided to take into account the public health in developing countries because HIV. And it was a creation of a global fund for HIV, TB, and malaria to improve access and to put money on that. And now in all the political meetings all around the world, public health is within the debate, within the agenda. This point is very, and after it was a cascade of events. The change of WTO, World Trade Organization, with compulsory license, with voluntary license, to improve access. And also, we have seen some private foundation, Clinton Foundation and Gates Foundation is something very important. And also all the association of patients, they say we exist and we need something. It's a big, big change. What we have done for TB, malaria, HIV, and suddenly they say, okay, but you have forgotten neglected tropical diseases. You know, it was a sort of chain, strong awareness to say, okay, don't forget sleeping sickness, leishmaniasis, Chagas, Buruli. And now they say, okay, but you know, in developed country, you have chronic diseases also. What about diabetes, oncology, and mental health? Nobody cares about mental health. Nobody cares about central nervous system. And you know, it was a sort of amount of topics that now we have no choice. Alors very often you say, okay, health has no price, but health has a cost. Health has a cost. This is a reality. And I think for an industry, because medicine is a part of the solution. Healthcare, to provide health. Health is a lot of things. And medicine is a part of health. And as an actor, in terms of medicines, we have to play a role. And we want to sit at the same table. You have to be on the same table, because without you feedback, is no research, is nothing. And this point is important. And another point, perhaps after I will come back about 4 pillars. It's now, you know what we call corporate social responsibility within the company? Now, the results of company are not only financial. It's not a billion of dollars and a lot of money. Now you have qualitative results. It's very, very important now, cynically speaking, because you have 12% of the investors, they want to put money in some company if they respect social responsibility. What are you doing for access in developing countries? What are you doing for disabled people? What are you doing for diversity? What are you doing about the social law for the people? What are you doing for human rights? And so forth. And now we need, and every year the big companies, they have a CSR report. It's very important, it changed. And you have a ranking of the company for CSR policy. Because some people say, I want to invest, but in this company. Because they are doing things, transparency for the patient. They involve patient and patient association for the research. And I think this point is also very important. Just to tell you that the landscape is changed. Even if the challenge is huge. You know, when you work in developing country, but even in developed country, you see a big, big, big gap. And we have to fulfill the gap all together. It's why it's very important now in many conferences and many reports from Marie-Paul Kenny and WHO about universal health coverage and many organizations, it's very important to have this vision. We hope a mid-term and not a long-term vision. But you know, we have to solve many political issues. What will be the budget for health in many countries? I remember a conference in Abuja in Nigeria, they say, we have to put 15% of the global budget of the country for health. The reality is 1%, 2%, 3%. The responsibility is for everybody, for all the actors. But what about the brain drain? Do you know that you have trained people? Because there is no health policy without human resources. You need nurses, you need doctors, health workers. You know that 8,000 nurses from many countries in Africa, they are coming in UK, in France, in Spain, because they can work in their country. How you can have a universal coverage without human resources is many responsibilities. And we have our responsibilities. And after, I will try to say a few words about some solution coming also from pharma industry.
So thank you. You hit a lot of issues that have been touched upon in the conference. You can see the inclusiveness, the seat at the table are big themes of this Congress, and I think something that's very appreciated by this audience. I will say that you brought in a lot of issues when I look across the 4 groups in terms of how you define this. I think there's a lot of commonality. We still have it at a very broad level. So I'd like to ask you to think about the specific barriers that you think are most important to address from your perspectives? We'll come back to solutions in a moment, but I'd like to get your perspectives on the barriers. And Stephen, I'll start with you again.
So my story continues with what could I identify that was globally applicable and globally equivalent and locally applicable. And I came up with 4. I'm not saying that there are only 4, but the 4 large ones were the power barrier, the economic barrier, the systemic barrier, and the patient barrier. There is another one, just not so much a barrier, but I think we probably all should keep in mind that the sheer scale of what we're talking about it's a big world out there. And I'd argue that whilst irrespective of location, each of these barriers apply and can be addressed in those locations. But I also recognize that many of us find it hard to keep a personal connection with the sheer scale. And there are a couple of examples of those. One recently is the polio program. The worldwide program to eradicate polio began in 1988. Today, it's estimated about 80% done. Population of the world in 1988, by the way, was 5 billion people. It's now 7 billion people. Populations often grow faster than programs, and conditions can deteriorate. So this is a really big success. Yes, it's 80%, it's a long time, but we've grown by 2 billion people. But in fact, because it's taken us so long, we now see that where we thought we'd actually controlled or eradicated polio, Syria, we now have emerging in the Syria refugee camps, polio being transmitted through contaminated water. So we now have a resurgence of something we thought we'd already done. The second thing to keep into scale is freedom. And it's one that I'll tease out a little bit later on when I explore the barriers. And again, when we're talking about global universal healthcare and access to it, we ought to remember that in the world today there are probably 25, possibly more, million people living in modern slavery. That's the population of Australia, the country I come from, where there probably are, in fact I'm quite sure, some of those slaves are to be found. So Universal has some really difficulties, some great difficulties for people who don't have homes, so to speak. And then you have cultural differences. And although cultural identification is incredibly important, it also comes up against the law. And this is particularly germane in the last couple of weeks in the UK, where the first charges have been laid under a 30-year-old law relating to female genital mutilation, FGM. It's taken 30 years, so one could say, well, perhaps it doesn't happen in the UK, perhaps. But current estimates are that there are 125 million women and girls in Africa and the Middle East who have undergone FGM. And even though it's been outlawed in most of those countries. And that is an enormous health issue. It leads to infections, it leads to bleeding, it leads to all sorts of mental health issues and distress. And that's just a group, a cultural grouping within national boundaries. So we need to bear in mind that whilst even I'm trying to address things that are talking about city locations, there are groups of people that ride over that. There are separate groups of people that could be beyond the access of universal healthcare. So the 4 barriers I've identified. The power barrier. The misuse of power, whether you're in Abu Dhabi or you're in Kinshasa, the misuse of power leads to violence, intolerance, and injustice, which in return causes disease, discrimination, disadvantage, and untold suffering. And we've talked about some of these already. It effectively puts universal health cover beyond the reach of hundreds of millions of people. So we must reduce violence. Violence causes disease. And it's not just violence towards people, although clearly violence we can identify in Central African Republic or in Syria. You can see enormous humanitarian crises. But it's also violence that is wreaked against the environment, and I'll come back to that again, that many of us in the first world order may not be directly involved in wreaking violence against other people, but certainly we do a fair amount about wreaking violence against the environment, and it will come back to us later. Taking my city's analogy, of the 10 healthiest cities in the world, only one, which is Helsinki, which is rated 8th, is on the United Nations Office of Drug and Crime top 61 homicide-related cities. It's rated number 55 on the scale. So there's evidence there, anecdotally, that that cities that are particularly healthy are not cities that particularly have high homicide rates, which is interesting. So I'd argue that we must reduce violence. We must reduce intolerance, or if you like, fundamentalism, embracing culture, faith, and tradition, but to the benefit of all people, enabling information and resources to be freely available, and protecting the privacy of people that access them. And we must reduce injustice in the world. The rule of law gives us the opportunity to have individual identities. It gives us the opportunity for public accountability. It ensures fair systems of service and service delivery. It empowers people to have better records. And it holds entities to account. So that's the power barrier, the barrier of violence, intolerance, and injustice. And it exists in Abu Dhabi, just like it exists in Kinshasa. In each of our communities and societies and cities, there is something there that we need to address as a barrier to universal health cover. The economic barrier is probably one that we're most familiar with, and that is that it seems that since the dawn of time, all economic activity has had an impact on the environment. Our ability to mitigate downstream problems from economic growth is clearly constrained by our very limited understanding of the complex systems of life on Earth and the cause and effect interactions over time, and often over a very long time. So we might come to believe that self-repair is possible, but it could easily be an incremental build-up to a catastrophic watershed. So hundreds of millions, if not billion or more people right across the world today are exposed to unnecessary and often unacceptable levels of disease due to the poor quality of the air they breathe, the poor quality of the water they drink, and/or the poor quality of the food they eat. Really good example of that is one that came up today. For example, that includes the need for us to eat clean food in the UK. Food that isn't contaminated with addictive fats, salts, and sugars that increase the continual purchasing of foods that are not good for us. So we as health consumers and patients must, that's a bit about undoing the barrier. One of the other things, by the way, is clean water doesn't come as boutique spring water in small plastic bottles. The systemic barrier is the third barrier, and that's really simply the bottom line has been sort of said here. An ounce of prevention is worth a pound of cure. It not only rings true today as it did in the 13th century when the phrase was coined, but it's relevant to global barriers of health. They say that knowledge is power, but timely knowledge is empowering, and it's important that we provide access to essential school and community health education in context, with a focus on action and prevention. But also, systemic barriers are about inaction and indifference. It's important that we have access to appropriate and essential resources. No one should suffer or die from an endemic condition which has been largely controlled or eradicated in the world elsewhere. I'll give you the example of TB. I guess, did anyone have a TB shot in, say, the 50s? Anyone have a TB shot in the 50s? Good, okay. Who had their TB shot in the 60s? All right, in the 70s, the TB shot? Okay, right. In the 80s, the TB shot? Yep, great. So we're starting to see that it's been going on for a very long time. If you're not sure, you can check your personal health record. It's just there. And in fact, that may be very important to us in the future, because in some jurisdictions, some places in the world where you can't afford to have health records well kept, or even electronic health records, personal health records like that scar, in the absence of any other record, could be really advantageous. So you would have thought that by now, we would have pretty much eradicated that if we'd only moved faster. And we haven't moved fast enough. And so now what we discover is, of course, we've got cases of not just drug-resistant TB, but extremely drug-resistant TB. And some of you will be aware very recently of reports in the UK that show that TB is actually on the rise in this country. Moreover, the TB is on the rise in South Africa and in Mozambique. In fact, Africa and Europe are the two areas in the world where TB is on the increase again. We're now looking at extreme drug-resistant TB, not the simple one we got the shot for back in the 60s, 50s, and whatever. So again, we really shouldn't allow any endemic condition that has been eradicated in one area to remain uneradicated elsewhere in the world, or we will all pay for it in the end. And the third systemic barrier is pain relief. Relief from pain should be, I believe is, a human right. And no one should have to endure unnecessary pain and suffering as the result of acute chronic illness. Or, again, in the first world, it's easy to identify in the 4/5 world, but an aging condition. Shingles is an enormously painful condition. A vaccine exists. There's quite a drama going on in Scotland at the moment. They're giving free vaccinations to 70 and 79-year-olds, but if you're 71 to 78, stiff luck, you'll have to run the risk of getting painful shingles until you get turned 79. And of course, I talked about the pain related to traditional identity like FGM, and of course, pain during end of life. So the systemic barriers are about ignorance, inaction, and indifference. And the fourth barrier, which will make me enormously popular with everyone in the room, myself included, is the patient barrier. It's in recent years, patient organisations have been beginning to talk about the two-way street of rights and responsibilities of patients. In addition to advocating for universal health cover, we must each identify and take up a personal responsibility to ensure our own optimal health, both within the context of our extant illness and condition, and beyond to our general health. So where there is any choice at all, we must look at ways of addressing that and taking up that responsibility. And there's a little illustration there about a story of, as many of you perhaps would know, the story of Sister Emmanuel in the Mokatan garbage dump in Cairo. And it's a really interesting story of empowerment brought about not by one woman, but rather, as it's actually said here, life in the grotesque corner of Cairo began to change, not through one person, but because of a partnership between one nun and thousands of garbage collectors. So the four barriers I see that apply in every city context, in every context globally, are power, the barrier of power, the barrier of economics, the barrier of systemic barriers, and the patient barrier themselves.
So you just gave a very large context to some issues. And so I would say to the group, start thinking about how you might prioritize for your town, your country, your community, which issues are most important for you to achieve if you're going to accomplish universal access. So keep thinking about that. We're going to come back to solutions in a moment, but at the moment I'd like to turn to Hernan and hear your thoughts on what are the most important barriers.
Yeah, thank you very much. I'd like to build on what you said before, not to repeat, but I think the first thing is that this access to what? And I made the distinction already. It's just health care. It's just, when I get ill, I have access. Is that what we're talking about, just that? Or is it that I have also access to health service in a broader perspective, to population health, public health, promotion, prevention? And because that has to do with the barriers, it will change in the sense that, for instance, I can think socioeconomic barriers that are broader. If I think other determinants of health influence in health, we know that health care only accounts for a certain proportion of the burden, of disease and mortality and so. And when you act on it, it will prevent so much. But so many factors affect health broadly. Are we only talking about physical health? Are we talking about emotional? Are we talking? So I think just to think about, because then the barriers vary and the policies vary. But in general, WHO thinks quite broadly. So in our definition, what health is not only the absence of disease, but it's the complete physical, et cetera, wellness. So this has to be thought, I think. So I go back to the barriers. Socioeconomic, you're totally right. if you are where to prioritize, you know, for instance, socioeconomic indicator will be illiteracy. I mean, it's the level of education. If somebody just can read, can write, I mean, it's a huge barrier. I mean, what does the healthcare delivery system have to do with that? So I think just to think, or just plain poverty. If I'm a single mom with many kids and I'm working to sustain that, I mean, just because I'm poor and I just can't delegate, there is another system there, you know, take care of, then I just have enormous limitation to access just anything because just my conditions. We talked about access, lack of water, sanitation. We know that a lot of diseases are transmitted because of poor hygiene, you know, and things like that. So we have to think that thing. Now, beyond that level of barrier, it's the affordability issues, the economic, and I won't repeat what has been said, but obviously I have a barrier if there isn't financing, especially if I'm poor. So a key barrier, and the WHO has lots of documents, this thing about what is called out-of-pocket payment. So at the point of service delivery, if somebody's asking me or the system is requesting payment at that state, that becomes an important barrier. We know that, for instance, certain countries spend more or less in health. There's public expenditure, there's private expenditure. In general, what we advocate is for people, thank you, not having to pay at the point of service delivery. And so there has to be a system of financing there that basically that lowers as much as possible that. And this could be a long topic of conversation. I cannot get into that one, but just to highlight the importance of the economic barriers at the point of service delivery, if I'm charged. And not only the official, but we know that in some places, in order to get seen, you need to pay like under the table, like a favor. So the corruption issue. So all this is related to, and it's not only at the point of service, but if I have to pay, and I'm very poor, and I have to take a bus, that is a barrier. Also, it's economic. I mean, I have to, and the opportunity cost, I have to stop working to go there. So all of this is in the economic sphere. Another very important one is actually it's geographical or physical. I mean, distance, obviously, it's important. And that's why primary care is so important, because primary care is a strategy that brings care closer to where people live, they study, they work. So because you can have this kind of facilities closer to people rather than just building hospitals. Hospitals tend to be further away. So basically a barrier to access is how close, how much time takes you to get to but it's not only that. Even, for instance, for disabled people, if there are no like ramps for wheelchairs or things like that. I mean, so it's not only that it's close, but it's built in a way where people can access, you know, easily the facilities. Another group of barriers have to do with the organization, which is the quality, like we referred. There's enough resources, there's enough, you know, practitioners for the demand, there's enough supplies, that there is enough medicines, that there's this issue, and it's organized in a way that it provides the most quality and the most and safe care. So this is when I already arrive, basically I get good care and I don't get bad care. We know that in many places care is very bad. I mean, many times it just won't make any difference at the end, but sometimes it will harm. Right. So this is an incredible barrier. So even if I get there, would this be universal health care? So it has to have the connotation of quality, because it's not just getting there and receiving something. It has to be effective, and it has to really make a difference in the positive way. And then I think along the lines of what you were saying before, also it's the issue about the acceptability. Basically, it's the issue about whether there's a conformity of the services in relation to my cultural preferences. And here many issues, for instance, languages. In many places there are many distinct languages within a society. Is that service available with my native language, indigenous populations, for instance? And cultural awareness, cultural sensitive services, it's also an important barrier. In many places, they have done incredible investments for structure. It's not culturally sensitive, and people just don't show up. And they're closed, somebody's paying for them, but they're just not what culturally and I think your last point is very important. We have to see that the issue about the partnerships, I mean, people have their own responsibilities. And here, there might be issues of mistrust with the system or things like that, also with the notion of because of any condition, you know. So we have to always get involved, the people, the community into this, because they have to be part as well. We have to really understand they are key partners. I mean, so strategies like self-care, self-management, and so on, and chronic diseases, so it's so important. If I don't want to cooperate, I see myself like totally away from the system. I just want to receive. Obviously, this is another barrier. I'll stop there.
Terrific. So Otmar and Robert, I'm going to ask you to add additional barriers that have not been addressed, but I'm going to give you the first crack at solutions or strategies for solutions. So Otmar, if you would go next.
Well, I think I would agree with most of what has been said, although I would certainly sort a little bit different and would stress the emphasis or put the emphasis a little bit different to the things. May have to do with the fact that we are living in the real world and faced with real problems and see what are the numbers and what are the problems coming up to us. When it comes to the barriers, and as I said, you will certainly hear some overlap in that, and clearly you have mentioned it before, the sheer unavailability of resources, be it human or material resources, is currently problem number one in this world, very clearly. Just think about the fact that you have about 90% of all the health professionals living in more or less the rich countries of this world, and vice versa, you have the highest burden of disease in the poorest countries of this world. So this mismatch of human resources in combination with a mismatch of material resources is certainly problem number one. Second, the inability to pay for services. You made it very clear, you said at the point of service. I think that is an important point, but in general, there is an inability to pay for the services in general, so they are not being paid for. And looking to that from the other side, I think, and that may be already some part of the answer, what we are missing in many parts of this world are systems of solidarity to come up for the cost of healthcare to cover that, so that there is really support for those who are in need by those who are able to provide this support and give this support. And that's something that in many parts of this world is simply not existing, so that there is no balance and no support for those who are in need of that. Violence and suppression, it has been mentioned, is certainly one of the problems we see around the globe. That access is being denied or very difficult to get, whether that is by war, crime, or discrimination of women in many parts of this world. Female genital mutilation has been mentioned, but it's only one part of it. There are parts of this world where women simply are not allowed to go and see a doctor. If the man doesn't bring them there or allows them to go there. Not to speak about more subtle ways of discrimination. Children very often don't get that, just to give you some examples. And other minorities or ethnic groups, for instance, which have a problem to go there. We have seen that in Europe even. Think about the war in former Yugoslavia when it broke down. So people wouldn't go to a hospital if that hospital was dominated by or served by the other side, by the other group, whether that was Serbs versus Croats or Bosnians, we have seen these problems of violence and suppression in many parts, and we still see them, and see them also in rich countries. Unfortunately, there's also a neglect denying those problems in many countries of this world. Another problem is rationing by political or economic reasons. The rationing comes in sometimes explicit, very often inexplicit and hidden. Often it is being put in a disguise. Politicians talking about quality of care, indeed what they mean, they don't want to pay for it. That's something which we find in many countries, including the very rich countries of this world. We have a lack of education that we see as a problem, bringing barrier to health. I'm coming from a country in Germany, which has certainly a very equal access to healthcare. In my city in Cologne, it's not that the split between rich and poor is that big as it is in many parts of the world. All people more or less have the access to the very same doctors, the very same hospitals. You can reach them with public transport within a couple of minutes. And yet what we see is that in one quarter, for instance, neonatal mortality is much higher than in another one. And if you look why that is, you come to the question, well, it's probably because the people in some of the parts are not seeking the healthcare or are not able to have a healthy living, which part is based on education and a lack of education in that. And another one which we have been dealing with within the World Health Professional Alliance quite often as a topic is the fact of stigmatization. Building up stigma against certain diseases is a factor that is not limited to a certain type of economy. It's something that happens in many countries. For many of the diseases, especially mental diseases, but also others, like for instance tuberculosis, it's a big problem to come in and get the service you need for that. So it's also something we have to overcome. So these are 6 points in line items, so to speak, where I see the barriers. You probably have seen many of those are very concordant with what we have heard, just in a different order in that. If you ask me for the overarching issue, I would say these are the social determinants of health. Mm-hmm. I think these are the overarching denominator for what we are looking at. It's a question of the circumstances we are born in, we live in, we work in, and we die in. And those are issues which we haven't addressed enough in the past. And if we want to have really not only equal access but equitable access to healthcare, then I think the social determinants of health are the ones who have to be addressed and have to be spoken about more.
Terrific, thank you. So Robert, again, I would ask you to provide your challenges that have not been articulated, but I'd also ask you to provide a solution or a strategy that you've seen successful or would recommend as innovative. And I want to remind the panel actually to do this as briefly as we can, because we're now down to 30 minutes. And I want to make sure that the audience has an opportunity for Q&A.
Okay, Marc. I see 4 pillars, solution and also some barriers. We speak a lot about innovation in all the speeches. I will try to be a little iconoclast, perhaps a different one. For sure, innovation is something very important. Mm-hmm. But innovation is tomorrow.
That's right. That's right.
Today, the problem is access. And what do we call innovation? You are patient, association of patients. Innovation is not only new chemical entities. A fixed dose combination can change the life of the people, of the patient, of us. I remember my first patient with HIV. In the beginning of the treatment was 25 pills per day. Now we have 1, 2, 3 pills per day. With the same family. It was not big innovation between the first compound and now. TB, we speak about TB. Active TB, I don't speak about resistant TB. It's 6 months treatment. Without fixed dose combination, during 2 months you have to take 4 compounds. Rifampicin, isoniazid, ethambutol, pyrazidamide. It's 25 pills per day. If fixed dose combination, 4 pills. This is innovation. It changes the life of the patient. Compliance with the treatment is a key point. You know this point. It's very important. It changes the life. It's why we take into consideration within our research center this type of things and devices and many things like that. And when you put vaccine, how many shots you have to do, if you make some combination of vaccine, it's only one, you have 6 diseases or 5 diseases that you can prevent. It's something very important. We need innovation for sure, but it's tomorrow. What about today? What about today? The gap. Availability. You say, all my colleagues, okay, it's good to have the product in the capital. What about the distribution? What about the cold chain? What is the supply chain? And to reach the community, to reach the patient, is not so easy. It's very complex in many countries. Okay, affordability, price. It's a very important one, about price and the pharma industry. But I will tell you something. It's not only myself, enfin, my company. We know that the growth of big pharma, and I say big pharma, will come from the south, where the needs are so important. But if we want to be present, we have to change the business model. We have to change the business model. With volume, with generics, we are completely open. If not, what is the risk? I want to be very transparent with you. The risk we'll have tomorrow, if we don't apply, and we are in a crossroad, take the good direction, you will have a big pharma with a research center for developed country, very high price, high margin, few volumes. And another one, I have nothing against India, nothing against China, but they will make volumes. We can compete in the same direction. And my department is a pilot department, access to medicine, to show that we can compete with the same rules, with quality for sure. And this is very important, pharma industry, affordability. And we think about that. Tiered pricing. What is tiered pricing? It's according to the income of the population, you will have a price. And the people they can pay, they pay. The others, they... The second one, social security, insurance, private, public insurance. Now we have a lot of pilot projects, what we call micro-insurance. I will give you an example. In sub-Saharan Africa, the population, they spend between 2 to 7 US dollars per person and per year for medicines. You know, for medicines. We have seen that we can cover 80%, 85% of all the main diseases with 20 US per person and per year. The cost is 20 million for 1 million people, roughly speaking. But it works if you have a chain of services. You need a rationalization of the treatment. Say for this disease, this is this product. Use essential medicine. We need that. And also the doctors, they haven't to say something under the table. One of my colleagues, but it's a reality. And we haven't to be completely blind, you know. In France, in UK, I don't know in Germany, you have a medicine with 2 speeds. To reach some big specialists, you have to put money under the table, even if you have social security. This is a reality. You know that as a patient. But it's a reality. It's why also it's a political concept. We need rules, we need law. But micro-insurance, I think, if we have all the chain of health services, could be a solution. I have 2 pilot projects, one in Benin, one in Madagascar, on that. But the people are ready to pay a little if the services is good. But we have to convince also them. And affordability. Or for sure, quality of care, quality of medicines. I have seen here in the lobby the problem of counterfeiting. It's a big, big problem. Counterfeiting medicine is a big problem. But why the people are going outside on the street to buy drugs? Because they can buy the good drugs. They have not enough money. But the public health, it's very important with counterfeiting products. Because they take antibiotics. If it's not good dosage, you will induce some resistance. And we have seen for TB, we have seen for malaria. I wanted to add something, Marc. Very often, and I say in the beginning, health is cost. But health is also energy for development. You give job for the people, for nurses, and if they receive money, they will spend money. And the cost of diseases, you know, on the African continent, the cost of malaria is 12 billion US dollars. 12 billion the cost. You know, it's something not going for economy, for development. It's why we have to convince the government we can invest on health. Health is energy for development. And really, thank you to speak about stigmatization. Because for me, I put here big one on stigmatization because I'm living that. I don't want to tell you which country I was a few weeks ago in a country, in a mental health hospital. This is jail, this is not hospital. And patients with mental health, they are patients. And in developed countries, they are outside. We have seen the same for HIV people. It was a stigmatization, you know, homosexual, hemophilus, and so forth. Oh, it's very dangerous. We don't want to have any contact. But HIV was a physical death, mental health, social death. And it's why we have to convince in the level of government that they have to do something for that. Just to give you an example, you take epilepsy. You know what is epilepsy? It's a lot of patients around the world, almost 1 billion, suffering from epilepsy. Epilepsy, if you have seen an epileptic seizure, you're afraid. It's something coming from we don't know. The patient is bewitched, he has the devil within his body. And they exclusion from the community. You know what is the cost of a treatment of epilepsy? The cost is coming from big, big pharma, bad people. No, I'm sorry. Joke. No, but you know what is the cost? You know, is less than €2 per person and per year to treat a patient with epilepsy. But the first thing is not the drug. The first thing is to convince health authority to put some money on this disease. Same for mental health. And to also to train nurses, doctors, family to say, don't be afraid. This is a disease. And as a disease, you can manage this disease. Political concern, awareness. And I know now at WHO, and we have some program on epilepsy and mental health, they are convinced it's a very important problem. It's 1% of the population of the world, the risk. It's a second burden within the few years, mental central nervous system disease. And some solution. And I think IAPO, you show us some solution. I think IAPO is alliance. Alliance. It's not each association of patients working in his country or his town. You make an alliance to be much more powerful. But we think about that. Very often say, oh, big pharma, why GSK is doing this one, Sanofi is doing this one, Pfizer, why not? You don't think about alliance. And since 5 years, we create an informal group called CEO, Chief Executive Officer Roundtable, with the 12 most important pharma, plus Bill Gates. With Bill Gates. And why? No, but why I tell you that? Because next week, we have, it's once a year, the meeting in Paris of 12 CEO, only CEO. If a CEO can attend, nobody can replace him. And I know that my colleague John Pender will be here tomorrow. He's a Sherpa also of this initiative. They will come in Paris with Bill Gates next week. And it's an alliance where we have some common goals. First one, Margaret Chan will be with us, my dear Dr. Montenegro. She will come in Paris for a meeting, a closed meeting, and a public meeting in Institut Pasteur. We have NTD, neglected tropical disease. It was a commitment made in London, January 2012, to say we can reach elimination of 10 over the 18 neglected tropical disease, we can reach elimination. And you say about polio, perhaps we'll, even if you have some barrier, reach elimination of polio. But we can reach elimination of sleeping sickness, Buruli ulcer, yawns, leprosy, soil-transmitted helminthiasis, and so on. Plus TB. We know that the solution for resistant TB is not one molecule. It will be a lot of molecules. It's why you make a sort of basket, a sort of patent pool. Okay, G&G, give us your molecule. Sanofi, give us GSK. And they finance some clinical trials to have the good one. And after we'll see how we'll share some incentive. But alone is impossible. It's partnership between different actors, but partnership within the same actor. pharma industry. We have seen alliance with Gavi. Gavi, Global Alliance for Vaccine and Immunization, is marvelous things. In the same alliance, you have private sector, public sector, academia, patient, Bill Gates, everybody. No, but don't laugh. Okay, I am sorry, Dr. Montenegro, to tell you something. The donation, Bill Gates, from his own pocket, he puts $30 billion on the table. Warren Buffett, 2 years ago, he came, he put $37 billion on the same table for the same foundation. And you have a private foundation with a capitalization of almost 70 billion US. They can't spend this money. But the revenue is between 2.53 billion US dollar. A part is from program in the US, but a big part from public health. Is 2.5 times more than the WHO budget. Right. It's a reality. It's a risk because private. But they take professional people and they try, and they are doing very good things. A lot of partnership. I think it is also very important. And for immunization, we made a lot of progress. A lot of progress. When you see the global coverture, in many countries is 80% of the children, the birth cohort and the population is covered for many diseases. It's why we have to be optimistic. But I told you in the beginning, I will finish with this one, respect. Respect. The time of polemics is finished. I have no time to tell you we made a lot of mistakes, big pharma. But this time is finished. We have no choice. If we want to fulfill the gap, to reach one day universal health care, we need to work together with you, with WHO, with academia, with everybody. If not, it will be a failure, and our children, they say, we haven't to fail. We need to be successful. Thank you.
It's a great point to end on. I really appreciate the point on collaboration and respect. I think that's critical, and that's something that has come up over and over during this Congress. I will say with respect to Bill Gates, they've done some great work, and they've done some great collaborations. They have not collaborated as closely with this community.
No.
So I would encourage them in your efforts to engage with us. As
I
we
will tell him next week. I will tell him next week.
We thank you profusely.
I will be your ambassador.
Otmar, would you like to address strategies for solutions?
Yeah, thank you very much. The wonderful it is the work that has been done by some private foundations. The question whether people get the healthcare they need, and I include prevention and rehabilitation to that, cannot be at the grace of a private foundation. I'm sorry. It has to come from what our states are and how our states work. And a state that doesn't provide this is not a good state. Yes, there are some parts in this world which are very poor, and there are some countries where you clearly can see they never ever will make it, simply because there are no resources in their states, in their territories that they can use and can mobilize, and that will not change. But those are only a very few ones. If you look to the vast majority of states that we see in this world, they are actually not that poor. Think about most of the African states. They have a lot of resources, they have a lot of good people, and yet what they provide to their patients, to their people in healthcare, whether that is public healthcare or curative care or rehabilitation, is absolutely lousy. Instead, these people enjoy much more to have a nice wall with their neighbors, or if the neighbors are not available, to have that with their own people. And that is where money is going through. That is where the resources are going to. In many countries of this world, in many parts of this world. If that money, if just a fraction of that money that is being spent for weapons would be put into healthcare, we probably wouldn't be discussing problems. That's a reality. That's really a reality. It's not a fantasy. That is just a small fraction of that money that has been used. So what we're discussing here is a matter of justice. And this is something which we have to achieve. Now, there are different types of justice you can think of. A Platonian one, maybe based on merits. Very difficult for healthcare. For a physician, that's something you cannot judge on, whom to give care and whom to provide access to care based on merits. Probably not a viable concept for that. Utilitarian. The greatest good for the greatest number. Certainly also not a principle that you wish your physician to follow, because you may be falling down at the end. So it's more a question of responsibility that we pay to each other in this world. So I'm clearly speaking in favor of a Kantian approach here to solve this problem. But I think that is something where we have to address, and I'm coming back to that, the social determinants of health. Those are the key points we have to ask for and have to look for in order to provide health care. You gave very nice examples on single diseases that are being addressed. I would like to remind you that the past approaches which we had to cure only a few diseases did not really work out. The focusing on just a few lines of diseases which we had in the past were not really helpful. Actually, in some of the countries, they produced more problems than solutions. So what we really have to find, and I agree completely with the World Health Organization, is a health system strengthening approach that has to be done. The necessary resources for the health systems have to be brought up and have to be put in. And here I agree again with you. We should not be talking about cost. That's a completely nonsense concept when it comes to healthcare to talk about cost. Those are, like in other parts of economies, turnovers and not costs. Although I'm not a person who is in favor of commercializing or commoditizing healthcare, not at all. But what we are doing is we are really producing a value for societies with that, whether that is the pharmaceutical industry, whether those are the nurses, whether this is the public health service, whether those are the physicians working in that service, and all the others participating in that. And this turnover produces a lot of revenue in healthcare. It is really value that we are producing for you. Not only a humanitarian value by health, it's also a real material economic value that is being produced for the countries that invest in their health systems. And again, I completely agree with you, Hernan. It is not only the curative care, there is also a side in that which is public health, which is prevention, health education, and of course also rehabilitation that has to be done. But there are no trade-offs. All three have to be done. It's not that you can select and say, well, we do the one and don't do the other. That's not possible. You have to do it all. And again, I say it can be done. What I would hope is that healthcare systems are under the responsibility of governments, or better the legislators, to install healthcare systems, but then to run them without the day-to-day political influence. Whenever politicians have their fingers into the healthcare system, it usually is a mess. And usually doesn't work. So there is a responsibility by the political system to install healthcare system, make them running, and also to keep them accountable. I don't disagree with that. Maybe through the legal system or through a supervisory system, but I think when it comes to the running, it's like with any other part of the economy, it's better than governments stay out of that because they usually don't do quite well with that. The word I mentioned, solidarity, I think to me is a very important factor. I think there has to be a balancing in those systems. In the end, it has to bring a system that is accessible to anybody and affordable at the point of service. Hernan mentioned that. There is a discussion about co-payments or not. If the co-payments are symbolic, that's certainly not a big problem. But I would agree if the co-payments are substantial, they are limiting the access to the service very easily and very soon. So they are really something we have to keep in mind and have to keep down. But I think, again, that is something that can be done. Although I would agree there is no ideal system in this world, and also France, which has been rated #1 by World Health Report 2000, has its problems. If you are in a lucky situation that you have a very nice co-insurance, it's easier for you to get your service. And if you're well educated, it's easier to get a service than if you are not. And there is no ideal situation so far. But bottom line is, it is already much closer to universal healthcare systems than many other systems of this world. And for you as a patient, I think it's a pretty safe place to be compared to other places in this world. I can tell you because I'm currently living in France and I'm part of the France health insurance there, the social insurance in France. So we have very good examples in this world where the solidarity works. We have to address more the social determinants of health. Even in the very rich and affluent countries, we haven't done enough of that. We have inequality in those countries as well. We can address those. It's not that we don't know about the problems. We have identified the problems and we can do something about it and address them. Yes, this is not only a part of health, it's also a part of other parts of society, of education, for instance, of social laws, of economic laws we have and economic conditions we create. But again, I think it can be addressed. And as I said in the beginning, it can also be addressed in those countries which we deem very poor. If they focus really on their strength and on their responsibility to the people they have, I'm pretty sure the situation could be much better than it is right now. Many, many people would not have to suffer that much as they have to suffer right now. Thank you.
Absolutely. Appreciate that. Hernan.
Yeah, thank you. Well, I agree that this is a goal, is a vision. What we really are aiming is improve health outcomes, people's satisfaction and so on, but it can be stated like a vision that can unify different actors. That everybody, all people around the world have, access to this comprehensive, high quality that doesn't impoverish them. So this is a very important political goal that's being discussed at the global level. And I think it can be done. It can be done. We can do it. So we have to look at this optimistically. Why we're saying this, actually countries not having enough resources is not an excuse. Actually, there are some countries around the world with, one would judge, very little resources. They have been able to do fantastic things. So what it means is that you require incredible political commitment and working in alliances. That's why it's so important what you're doing here. Being a patient organization, you play an incredible role at the political level in different levels of society and government to move this and interacting with all of the actors. So we need incredible political commitment at all levels. And I think organizations such as yours and the fact that you're discussing here is just fundamental. We cannot move forward, and this has been said over and over, without partnerships and alliances. It's not only just one entity that can deal with this. It has to be a concerted effort, guided by this vision that bring us all together to attain it. I think that the arguments, the rationale are very important. Why? And have been also mentioned, because with better health, countries develop better. It's more like economic terms, but also the right approach. It's a right. It's a basic right of everybody. And we know that in countries, when you run surveys, health ranks number 1 or number 2 in majority. So it's for politicians, this is an important topic. They want to do. There are other things as well, but in general, it ranks very high in the agenda. And we have to work again with alliances, with partnerships, looking that political will, making all this progress, at all levels. It can be done. We have to learn from those countries or communities where it has been done, even in very adverse settings. The other thing I think it's important, I think Otmar mentioned this and we totally agree, we need not just quick fixes and just magic bullets or just single interventions. We need to build basically systems, institutions, where different actors basically evolve, because if not, you have the issue of also sustainability or draining out systems by, just this vertical programs, for instance, just for a single disease solutions, basically when sometimes it undermines the overall system and things like that. I think financing is very important, and the notion of solidarity, I think this is very important in financing. So when we build, the financing, we try to be in pooling of risks. So for instance, the young help finance the care for the elderly, or the non-poor for the poor. So all of this contribute in a progressive way, where the ones who have more means basically help the ones who have less. So can be discussed many options. There are many technical options, not the point, but we need to build sustainable and good systems that basically don't create barriers. I think we need to reform the models of care. So we aim to quality and safety, for instance, so we strengthen primary care and so on. There are many things that can be done in reforming the model of care. And then I think the last point, because I know we're reaching the last, is that there is no really single magic solution. It's not like a model that you would export. Everything has to be context specific, tailored to the realities of each community. So that's why as WHO, we're not like recommending again, a specific model, or we know certain principles, attributes that seem to be important, but it has to be adjusted to the local need and tailored. But there are many lessons and commonalities that explain success when you're moving towards this, that we have to learn from and adjust to the local context. I think I'll stop there. Thank you.
Some really important points. I appreciate that. Stephen, it's your job to provide the final say on solutions. While we do that, this will be the final answer to the questions I have. So I want you in the audience to be thinking about your questions, and we're going to give one of our microphones to somebody who will be using it so people in the audience can speak. Okay. Sorry.
Never worked with children and animals, and I'm getting a very clear wind up from a golden Labrador over here. Look, right, the power barrier that we've all been talking about, violence, intolerance, injustice, the power breaker, that everyone has to work for greater peace and harmony with the people on the planet, greater tolerance, and ensuring the right of a voice, often a vote, and ensuring that we use it. In a nutshell, all people must have a voice and use it judiciously with tolerance. And for Europeans in the room, it's probably time to hang your heads in shame, or us to hang our heads in shame, that since elections began in 1979, our turnout rate has gone down, down, down. In the last 3 elections, it's been less than 50% who have turned out in Europe to vote for a government. In other words, to put health on the agenda. Shame.
Good point.
Thank you. The economic barriers that we were talking about before, I think what we're really saying here is that to ensure that all economic activity of companies, governments and NGOs need to be approved, measured and reported in terms of the advancement of universal health coverage. In essence, I don't see why universal health why universal healthcare, UHC, shouldn't become the 4th bottom line. We've all become familiar talking about the triple bottom line. Well, it's a quadruple bottom line, and I think we should be pushing for that. Basically, everybody, whether they're a government or a company or an NGO, ought to be reporting not only on their profit, not only on their social responsibility, not only on their environmental responsibility, but specifically what they have done to advance UHC from all the way through the chain, from the suppliers to the employees, to the distributors, to the retailers, to the consumers, right across the world. We should be reporting how we've improved UHC. The systematic barrier we talked about, particularly ignorance, inaction, and indifference. In the systematic barrier, in a nutshell, I think we must be prepared to allocate and divert some resources, possibly away from healthcare needs of today, to invest in reducing the healthcare burdens of tomorrow.
Yes.
And it's time for us to also stand up and be counted in that space.
Absolutely.
And the patient barrier, well, we must do our best and use our best endeavors to ensure our general health and well-being and to maximize our health outcomes in line with our patient journey. So where there is any choice at all, we must eat what is good for us in the context of what is healthy eating. We must drink what is good for us in the context of what is healthy drinking for us. We must do what is good for us in the context of what physical activity is relevant. And we must proactively monitor our health. This one may sound much better. In a nutshell, each of us, regardless of medical condition, life circumstances, must act to eat well, drink well, do well, and keep well. I fear my well is not the well you're thinking. Thank you.
Thank you. I appreciate that. So people who have questions, if you would raise your hands. I will say that you are seeing a lot of common themes in the barriers and the solutions. What strikes me is that we need to start thinking about what are the strategies to overcome some of the barriers within our communities, and how we might collaborate to prioritize them and implement them and operationalize them. But I see we have a hand here. If you would identify yourself and state your question or comment. I will ask that we have limited time, and I'm expecting there'll be a lot of people who have questions. Please don't make speeches. Please put out your comment or issue your question. Thank you.
My name's Rosemary, the Arrhythmia Alliance. Both questions directly. I'm sorry they took your names down, but World Health Organization, thank you. We had, firstly, to agree with you about the political aspect. We've had yesterday a very good speaker from Thailand who, and she explained that when the local government were tasked with starting to help more and to raise funds and so on, and then they were very pleased because they were getting more votes and so on. So just to back you up on that. But I want to ask you about Stephen's point. He mentioned about lack of water and food. And in Britain, as you'll be aware, research showed that mortality rates fell in Britain. Actually nothing, I'm sorry about this, nothing to do with medicine, but it was when we had better food. So I know it's a broader question, but can you include that in your remit when you're doing your public health activities?
Great. And if there are other people with questions, please raise your hand.
Thank you very much. Wim Wientjens from the International Diabetes Federation. My brain is not full, and I'm always looking to such a panels, like I'm looking to television and moments of zap to another channel. So I am really impressed by all of you, but I certainly wouldn't zap when Monsieur Sanofi was speaking. You got applauses and so on. You are, but I'm at the same time member of the management board of the European Medicine Agency. So I must be very careful with conflicts of interest to say it was a good speech. But how are you doing all your conflicts of interest? It must be marvelous what they're doing, and I'm happy with that. And I have only a simple question. The question is, do you agree with me? So then only to say yes or no. And I think that it was really interesting what was happening today in all the working groups and so on. And for me is a little bit, and I can recognize it in that, think globally, act locally, and then locally can be a country or cities, but do it individually. And that is so important for all of us. I'm a long life diseases with an S, and you must do it really individually. And all the problems, all the solutions are on the 3 levels. And I do hope France, Germany, Chile, Australia. Now, my question is, do you agree with me?
My answer is, thank God you didn't turn off while I was talking.
There's a question here and over here, but I will say you laid out a nice framework for the articulation of a strategy. So I really appreciate that comment. Yep.
Yes, I'm Shorbani Chakraborty from Merck Serono. And I like the idea about partnership and collaboration, but I would like to ask all of you, how do you do that? You need to build trust. I was working for the World Bank for 15 years. I joined the industry last couple of months. And one of the things that I feel pretty clear about, the industry doesn't need to be defensive. We need to work in partnership with all of you. And I think we need your support in doing that. And I think we need the World Health Organization and other organizations to also be our partners. And when I go to countries, and I've been in dialogue with ministries of health in many countries, there's great distrust of the private sector. And so how do we work towards a framework for joint accountability and trust? Thank you.
So I will quickly respond to that because I think that is a fundamental component or core component of IAPO. It is an organization where the fundamental members are patient organizations, but we have in membership other organizations. Again, the governance is controlled by the patient organizations, but that collaboration leads to relationship building and trust building. And I think the challenge there is we sometimes think that we can engage in the moment and it's over. But there's a professor in the United States that talks about pre-engagement. If you think of engagement in the context of a marriage, you don't just meet somebody and marry them. You actually meet them, you get interested, you date, you get engaged, and then you have a commitment that forms the basis of a relationship. We're still in the very early phases of dating. And I think to your point, we've got to continue to date, but that's a really good point. Thank you.
Oh, could I just add to that, please? Apart from you start out by dating, and then in my day, you used to go stepping out before you actually went steady, before you actually got engaged. So it's actually quite a longer process, but then some people are older than others in the room. So again, there is stepping out before you can go steady yet. So we've got a way to go from dating. The other thing is, I would put you, sounds a bit cynical, but I think there are lessons to be learned there. Once upon a time, doctor knew best. That model didn't work. Once upon a time, the bank manager was our friend. That doesn't work either. So when you're doing this dating, remember those lessons of engagement.
We have a question in the back, and we can come here after.
Roger Kendall from Epilepsy Here, which is a local epilepsy charity. We know from although we are locally based, we know from our membership of the International Bureau for Epilepsy that although the problem you mentioned is there, at least 80% of the people in the world who have epilepsy have no access to modern epilepsy medication. And we would hope that it's not entirely the fault of the pharma industry. I wouldn't put it down to that, but I hope that by getting together in your partnership, as you suggest, that can be overcome. Because I've been in touch with people in Mali who in fact, have the highest difficulty in getting epilepsy medication, but nevertheless have the highest cost of it when they manage to do so.
Very quickly, perhaps, on your comment. The problem is not access to the new compound against epilepsy, even the previous one. If I take phenobarbital, the cost I told you is not a problem of cost. It's a problem of priority in the country. And we signed an agreement with WHO for epilepsy, to fight epilepsy, in 2 main countries, in Ghana and Vietnam. And now we take the decision in my department. We are present in 23 countries, in Africa, in Asia, in Latin America. we will produce some product in our plant in Senegal, in Dakar, with a very, very low cost. We want, you know, it's globally speaking, pharma, I don't want to enter in conflict of interest, this type of things. I'm not against, exist conflict of interest. The problem is to appear as a partner of public health, not only a provider of drugs. We need profit. We need profit, for sure, for research. We need innovation and we need to work. But also our own interest is to be close from the patient, close for the needs. And I told you again, the growth will come from the south. And for that, we have to be adapted for that. You know, we have to accept. If not, okay, it will be a political choice for the big pharma. But everybody is aware about that. We have to, in some country, to change the business model.
Terrific. I know we have a question here, and there's a question in the back, and I see another question over there. Microphone is coming to you. If you guys want to respond, please.
Jim Appleyard from the International College of Person-Centered Medicine. I'd like to raise the question of priorities. And with over 8 million child patients dying each year under the age of 5, I've just wondered whether the panel could understand why countries, even with small amount of money, don't do more about this. From treatable diseases, they're dying on treatable diseases. The treatment is available for them.
Would you like to, want to respond? Absolutely. And there's a person with a checkered shirt in the back will be next.
Yeah. Well, there has been a few questions, so just not one, but that have been addressed to me, or either, you know, in general. Just try to answer very briefly. The first one was on the fiscal and public government spending, and this has to do with the role of government in facilitating yourself. It's vital. I mean, this is very important. Government does have a responsibility in ensuring that, you know, all people have the best access possible of the best quality, and so on. And governments have different instruments: financing, regulation, etc., bureaucratic reforms, information, many policies. But we know, for instance, in terms of universal coverage, some countries just spend very little in health. And again, this, I'm not talking only the sum of the private and the public, but in the public, 2% of GDP or something. And so those countries really need to make an effort. And that has to do with allocating resources within many other priorities. But what we have seen where this is done, and there is political commitment, and especially countries that in the past weren't doing economic growth, now many low-income, middle-income, emerging economies are having a good time. Well, what are they doing with those new? And here's where health becomes a priority, and they start. So it's very important. So we see that a lot of those countries basically have also increased expenditure, public expenditure into public health systems. And there are different numbers there in terms of the proportion of the GDP that goes to this, and so on. Proportion within the government budget, all those things can be seen. This goes to a question about water and food is very important. I mean, and this is why I came out, I think, very clearly from this panel. There's these determinants of health that are so important, from the diet, what you're eating, that you kept saying. It's so important. If we don't act at that level, I mean, we're going to basically miss spending at the end of the others. With the case is already very advanced, and you want to be efficient. You want to be. So the issue about promotion, prevention, social determinants is so important. I think this has come across very, very important. Very briefly, then, in terms of perhaps the priorities. Why it doesn't happen? I mean, it's basically the question: why are not governments investing enough? I mean, that's depends on each country. I think it has to do with history, sometimes with conflicts, with the quality of the decision-making process. Are people participating? And this is an important area. What we see where this is very important is when countries are trying to define what are the health problems to incorporate the community into those discussions, try to reach, and then when they define the services to be provided, you have to make choices. You have to prioritize, and I think there are important variables that can be used, and there are techniques. But again, it comes to, I think the quality of the political processes in each country, the history that might explain or not. And it's just, this is a very general answer, but I think where it's not happening, the priorities are not right, there's probably what we call a problem of governance, where those priorities that should be tackled, they are not really addressed, and there is no political will. There's problems with institutions, money not following, the priorities, and so on. I'll stop there because.
Excellent. And Otmar?
Yeah, I would like to respond to Jim's question, the question why children are so much underserved, and they are being underserved and disadvantaged in all of our societies. Certainly with different degrees, but they are certainly at the low end of our political attention, and it has to do, of course, with the fact that they have no voice. So they cannot vote, they cannot react, they cannot protest, they cannot pay to do something different. And that means usually they are most disadvantaged, and they, with me, come together in the same group with the very severe mentally ill patients. And what I will always tell my students and co-workers is, instead of looking on health statistics and evaluations of a country, if you have a chance to look on mental institutions and how children are being dealt with and treated, I think you get very easily a very clear idea on how good that healthcare system is. And that gives you a very solid impression on how the attitude is towards dealing with persons and with patients. We still are in the learning phase. Even in the rich countries, we have not yet understood how really to behave and deal with children in healthcare, whether that is public health or curative health. We are not really adjusted to serve them really well and appropriate enough. When it comes to public health, think about the way we deal with food in schools. Not really good. Think about how we deal with smoking in the vicinity of children. Just recently, I think this week, there has been a very nice study in London showing that smoking prohibition has already a strong effect on preterm birth and asthma. We could do much more. We could tell people, as you cannot beat your children, you should not smoke in the vicinity of your child. Why don't we do that? I think that's a very simple message, doesn't cost anything, has tremendous effect, and yet we don't do it because the children don't stand up and the children don't fight back. And as I said, it's not only the children, unfortunately, the other very disadvantaged group is the severe mentally ill, which have exactly the same problem. And it's something we have to address, definitely.
So we have two more questions. Yeah, absolutely. I'm going to let you respond to that, but I just want to make it, Stephen, and would you put your hand up so we know where the phone? Thank you. So you'll be the last two last questions. Thank you.
I'll make a very quick point. Sometimes also the road to hell is paved with good intentions, and we recently had a report in this last 2 weeks. Again, I think it was in Lancet, but I'm not sure, of parents who would step outside to smoke and not exposing their children. Then when they'd come back in and they'd stand in the doorway and they came back in, and even then that secondary smoking there was evidence the secondary smoking was affecting the lungs of their children. So it's not easy. What I'd like to do is pick up on this word. But that doesn't speak against my argument. No, it's not. No, just an opposite. No, it's not to speak against it. It's to add to what you're saying. It's exactly the point you're saying. Written large because you think you're doing the right thing and you're not. The key thing I want to get across, though, is apart from the fact that there are 4 European males here, it is about worldview that I'd like to go back to the children issue. And whilst I recognise that it's a cultural, indeed a traditional cultural worldview to hold about female genital mutilation, we have as a globe recognised that it is not an acceptable practice and it has been outlawed. So I can hear you say, why aren't we outlawing the poor treatment of children at the same time? And I think that worldview has limits and of tolerance and acceptability. And whilst FGM was not acceptable, what we do find acceptable, for example, in China when they introduced the baby hatcheries, where people could return the children that they value judgment, return the children that they couldn't manage for whatever reason. They were largely disabled in some way or another, or Down syndrome or other. And it was overwhelmed. I mean, so there's a worldview in a society that says, first of all, we will set up these baby hatches so you can return the children that you're not looking after. And that's one worldview. And then the second worldview is the parents going along saying, okay, here's mine, here's mine, here's mine. And so instead of being able to handle 1,000, which they thought they were going to get in one province, they had closer to 5,000 within the first 3 months. So, and again, that's a worldview that we need to get our heads around and not just necessarily say it's wrong.
So your question?
Yes, my name is Pierre Baneke from the MS Multiple Sclerosis International Federation. It was mentioned, I think by two of you, that single disease attention may be counterproductive in some cases. And I wonder if you could explain that, first of all, a bit more. The second thing is, of course, most of us here, and also that includes me, are from single disease organizations. Does that distort the priorities? We lobby for our disease. We lobby for research for that disease. We fundraise for that disease. We compete with each other in the fundraising for those diseases. But nevertheless, my father had multiple sclerosis, so I will work for multiple sclerosis. I'd very much welcome your reaction to that.
May I answer directly? Yeah, thank you very much. Well, and I would encourage you to go on with that, definitely. And it's your good right to stand for your interest and for a disease group you are representing or working for. There's no doubt about that. That is one thing, and I think that's an engagement that is extremely important and in many places utterly important. And as we said already, there are some disadvantaged groups which actually could get used more than that. The problem is when healthcare systems are not healthcare systems, but only the interests of some private foundations or some politicians which want to do something. What you then have is you may even have nice programs dealing, for instance, with HIV/AIDS and tuberculosis and maybe malaria and the river blindness, but everything else is then excluded. What does it mean? It means that all those patients, and unfortunately the patients in those poor countries which are served by those programs, take the freedom to get all the other diseases as well. They have multiple sclerosis, they have a heart infarct, they break their legs, they have mental illness, they have oral health problems, and then, well, you are not covered by a program. Same is true for a physician. Think you are a physician in such a country and you are not employed by one of those programs. The only thing you can do is go away. So getting a ticket for the United States or for Europe and work there, because if you're not in one of those programs, nothing happens. So I think this change in strategy, two things which we have seen a couple of years ago now, or in the very recent past, by WHO are really key strategies which are very important. Number one is a renaissance of primary care. And this is primary care in comprehensive healthcare systems. Primary care as the core building block of comprehensive healthcare system. Very important strategy, much better than what we had before, and I think much more realistic. And number two is healthcare system strengthening, so that you really cover the healthcare systems. And that does not mean that there is a disease not being taken care, but it means that there are diseases which are not being excluded, and that is what we had very often in the past. And yes, in many places there have been wonderful programs, and I'm not saying forget the programs, but please make sure that the systems are being developed and that everybody, every patient, get a chance to get the access that he needs and wants at the time he or she needs and wants it. Thank you.
I'll respond to the second half of that question. I know in the United States, many of the disease-specific organizations belong to the National Health Council, to accomplish those systemic issues that will help them accomplish their missions. So they can devote a certain part of their time in collaboration with others and to increase their strength on an issue that may not be condition specific but allow them to have impact. And I think there's an opportunity to do that through organizations like IAPO and others. But you're absolutely correct. You have limited time, limited resources to devote to those systemic issues. But once you prioritize what ones are most important for your organization, you can devote that in collaboration. But it's a really difficult issue to navigate. Our last question, please.
As we would advocate, as patient organizations, we would advocate a whole-person care regimen. And really that's what my colleague is saying, that whilst we still are to be treated for whatever our condition would be, CD or NCD, we expect to engage increasingly. We want to be at the center of the healthcare system as a whole of person, as an integrated model of healthcare, not people treating me as if I'm just one condition or another. Not ignoring the one condition, but treating me as a whole person.
Our last question, please.
So perhaps that's a perfect segue to my question. I'm very glad to hear wellness being discussed. I'm April Abernethy with the National Psoriasis Foundation, and in disclosure, I'm a primary care physician. I think wellness definitely belongs in the definition and conversation around healthcare and what that means as far as delivery of healthcare. I believe our system is somewhat broken because we are focused on disease care and disease management. But when we have endpoints and outcome measures and patient voices talking about the dire needs of that disease management, and we can't come to a consensus of how to best deliver care, how do we come together to define what wellness is, and how do we deliver care that includes that globally?
So you've given us a stumper.
No, I'm really, I used this expression yesterday or the day before. I think it goes to the heart of that this is my illness. This is my illness journey, if you like, my condition journey, and I need to be in the driving seat. And I'm not my illness. I am a person, first and foremost. And I think that's where you're coming from. So the dialogue is when you put the patient in the driving seat in respect of their particular condition, they're surrounded by health professionals and allied health professionals, not looking just at the illness, but looking at the whole person and the whole journey. Okay? And I think lots of our colleagues here, that's what they're advocating. They want a whole of journey and a whole of person approach.
And I see a lot of nodding heads, and that's again a potential area for collaboration. So I think it's critical.
Yeah, it's to build on what was just said just previously. Within WHO, we are developing a strategy we're calling people-centered and integrated health services. So that is like exactly that. And goes back again, did you look at the person, the context of the family, the community, and you're addressing hopefully the majority, if not all of the needs of that person independently? Because, for instance, it's with your question about disease specific. Today, with chronic care, for instance, and long-term care, and the aging of the population, you have people, many of them as they age, with a lot of not only just a single problem. And you need to address them, but even, with little kids, so it cannot be that you go and the system says, no, I'm sorry, I can just see you for this. If you something else, you're not covered, you're not seen, or go to some other place, find out. That is very inefficient also. And because when you do this program, so there are some very few indications that they are even discussed about when you might come, you basically those resources are located basically just for that and miss opportunities to do something else. And so we truly are advocating for this people-centered, integrated approach as a way basically to deal with the last round of comments, that we organize care around the people's needs, and it's not only the individual, but the individual, the concept of the family and the community.
So I'm actually going to ask each panelist to wrap up with 1 minute or less, and I'm going to have Robert go first. Thank you. We were short on microphones.
No, less. Just about this concern, we face the same difficulty within the company. Because you have the Department of Diabetes, Central Nervous System, Oncology, and so on. And I fight. I say you can cut health on slice. It's important to have one disease, but when we start to treat people with HIV in Africa, we have seen have HIV plus TB, co-infection. They could be diabetic people. They can have a depression, and so on. It's very important, but also within the company, we have to cut the silos. To say, okay, we know the relation between diabetes and infection, diabetes and TB, diabetes and depression, and so on, oncology and mental problem for the people because suffering. And it's why it's very important. We have to change the paradigm. It's not easy. It is not easy to find some transversal structure. And in my department, I think it's a pilot department with 40 people, access to medicine, I put everything. I put everything just to show the relation. And the risk is like, okay, TB alone, no. or something else. Absolutely. But just very quickly, I was very happy to share with you and to give you some messages. We are a partner. Don't think that pharma industry is only here to make some marketing and some lobbying. We need you need us, and all together. Again and again, if we want to fulfill the gap, we need to work. It's no choice. It's not a love story. It's not a love wedding. It's a reasonable wedding. And we know, and we know that very often a reasonable wedding is much more efficient than a love wedding. and really, thank you again to invite me. And I was very happy because I learned a lot of things with my colleagues and also with you. And good luck for the end of your meeting. Bye.
Omar, I'm so glad the wedding theme is continuing. Omar.
Where's the cake?
Just outside.
Well, let's talk about the cake. The good thing is, and I think that's really a perspective, is that more and more people are understanding that we are not talking about cost, that we are not talking about burdens, that we are talking about opportunities and economic development. And that is a good thing. I think there's really a chance that people understand that this world is changing, that people have rights, that the right to healthcare is there and is something that has to be acknowledged, that it means that something has to be done about it, that it's not only on paper, but also that this is a very big opportunity for development of nations, development of economies. And that is a message I think we should bring out much more positively. Because then we have a chance that people who are in charge of steering the money are listening more. Many of our economies are already service-based economies, and if you look to many parts of this world which are currently agricultural economies, especially in Africa, the only chance for development is going into being tertiary economies as well. They won't be big producers of goods. They will have to make this conversion very soon. And when it comes to this conversion, healthcare is really at the center part of it. And that means that there is really a big chance in what we are doing. And you, as an Alliance of Patients organization, have a very strong and important role in that. Because you can, in your partnership with the industry, with WHO, with the NGOs, with the health professionals that are working with you, and this partnership is there, we have really a chance to bring out this message. We are not demanding anything unfair. I think there's nothing wrong with it. And we can show and make the case that this is not only improving our societies, but our economies as well. Thank you very much.
Well, it's been a pleasure to be here, really, and we're going to be engaged with you as WHO in some other sessions, and we have this relationship going for some time, so very pleased to be here. I'd like to, congratulate you to bring this theme that allows, you know, a really big picture of the issues, and it's interesting because it's more system-wide. I think this is a very important step that you're looking at this angle. So I'd like to thank especially Joe for inviting me for this panel. I think it's been very interesting. I'd like to congratulate you for this. I'd like to ask you to keep working with us and with others to move forward this. Just to highlight, there's this key opportunity now in terms of the global development agenda after the 2015, or after the Millennium Development Goals, the MDGs. After 2015, we have to come at the global level, international, with a new set of priorities for the entire globe on the development agenda. And we should, all of us, work together to make sure, and this is what WHO is trying to do, that universal health coverage is part of that, like a good umbrella to really move forward the kind of things we have been discussing now. So again, you play a key role. We want to keep working with you on this, collaborating with you and with the other partners that have been mentioned here. So we all move forward this important agenda, and you play a key role at so many levels, at the individual levels, your families, your community, but you have much more power that you can exercise, you know, within society, that so we all come together to move forward this important goal. Thank you very much.
Thank you.
I'm not sure about entering a prenuptial agreement with Sanofi, but we could start dating. The global barriers to universal health coverage. I think I'd summarize this way. It's one world, one journey, one person, and 7 billion stories and counting. In this particular case, we are better together.
So I want to end by saying we're seeing a lot of common themes that gives IAPO an opportunity to develop tools as it's done in the past. For example, the biosimilars toolkit, where we could start to look at some of the common themes, some of the levels you'd want to address them, to start to identify what might be potential strategies that people could come together and coalesce on, because I think you nailed that on the head, so I appreciate that. While Joe comes up to give us some housekeeping rules, I just want to give another round of applause to our really terrific panel. Thank you.
Yeah, wow, what a panel. It really, I mean, it's a testament to the people on the stage that we've just had a 2-hour session at the end of the day when many of us have been working hard for 2 days. I'd like to ask you just to remain up here and we'll take a couple of photos and give you a small token to say thank you. But certainly, I don't know about our minds being full, but mine is absolutely buzzing now. And I think it really has, it's broadened the discussions that we've been having, and we can see the interconnections, and that's really exciting. So a few housekeeping announcements. Our evening programme, to which everybody is welcome, and I hope you will join us for a nice social event, starts with a reception sponsored by Medtronic at 7 o'clock, and that's in the foyer to this room. If I could ask you to please move out of this room very quickly after this session to allow the hotel team to set up the room for the Congress Gala dinner, which starts at 8 p.m. And the dinner includes the infamous IAPO quiz. Those of you that have been at a Congress before will know it's a bit like Marmite. I don't know if you know the spread. You either love it or you really hate it. Please remember to complete your evaluation cards. They are on the table. For the stream sessions, there are spare copies of the evaluation at the registration desk because a lot of us had to move out of them because the fire alarm stopped that happening. And then to tomorrow, please note that you need to have checked out of your bedroom before the session begins. and we will start at 9 a.m. tomorrow morning, where we'll continue with the third of the streamed sessions in equity, quality and financing, the 3 pillars. And that's going to be followed by our final keynote presentations and conclusions, hopefully bringing all of this wealth of information into a cohesive way forwards. And we have fantastic keynotes again. Mary-Paul Kearney, the Assistant Director General of Health Systems and Innovation from the WHO, and Sir Michael Hurst, the Global President of the International Diabetes Federation. So with that, I would like you to again thank all of the speakers, and also to Marc Boutin for chairing this session, and have a wonderful evening.